All right, let's dive into a clinical review focused on managing spinal cord injury. And to make it really stick, we're going to do it through a case study. We'll follow one patient, putting you in the driver's seat for all the key decisions. So, meet Alex. He's 28, and he's just come in with a new C6 spinal cord injury. He's your patient now. The clock is ticking. So tell me, as the clinician in charge, what's your first move? Where do you even begin? Okay, so here's our game plan for taking care of Alex. First, we'll figure out how to assess the injury itself. Then, we'll talk about predicting his recovery. After that, we've got to watch out for heart and lung complications. Then we'll get into the long-term stuff, urological monitoring and bone health. And we'll wrap it all up with a simple clinical checklist for you.
All right, first things first, we've got to assess the initial injury. When a patient like Alex rolls in, there is one step, one diagnostic test that is absolutely critical.
Look, we can't make a plan until we can see what we're dealing with, right? So what is that one single image you need to order stat to really get a handle on the damage inside Alex's spine? And the answer is a full cord MRI. This thing is a goldmine of information. We're not just confirming the C6 injury level, we're also looking at the cord signal, we're checking for any bleeding, any disc herniation, or even something called syringomyelia. Getting this comprehensive picture is literally the foundation for everything we're going to do next.
Okay, next up, predicting recovery. The MRI gives us the blueprint, right? It's the static, anatomical picture of the damage. But to have any chance of predicting Alex's functional outcome, we have to look beyond the image and assess the physiology. We need to see how the electrical circuits are working.
And that's where electrophysiology comes in. It's a game changer. We use two main tests, somatosensory evoked potentials, or SEEPs, and motor evoked potentials, or MEPs. Think of it like this. SEEPs check the sensory highway going up to the brain, while MEPs check the motor highway coming down from the brain. Getting this functional data helps us give a much more accurate prognosis for Alex. All right, section 3. This one's a big deal, the cardiopulmonary watch. In the early days after a high cervical injury like Alex has, you have to be on high alert for some really serious life-threatening complications. Things can go wrong, and they can go wrong fast. So we're basically keeping a hawk's eye on two major systems, the lungs and the heart. For the lungs, we're really worried about pneumonia and atelectasis. For the heart, we're looking out for super slow heart rates, bradyarrhythmias, and a potentially fatal blood pressure crisis called autonomic dysreflexia. You have to be watching for both, constantly. So how do we watch the lungs? Well, our go-to is the chest x-ray. Now, why is this so important? Someone with tetraplegia has a really hard time coughing effectively. That means they can't clear secretions out of their lungs, putting them at a huge risk for aspiration, which can quickly spiral into pneumonia or a collapsed lung. It's a simple image, but it's a vital screening tool. Now, for the heart, the ECG is our best friend. A C6 injury can seriously mess with the body's autopilot, the autonomic nervous system that controls the heart. This can cause the heart rate to drop, sometimes to dangerously low levels. The ECG lets us watch this in real time and catch those changes before they become a catastrophe. It's an absolutely essential part of acute care. Okay, moving on. Once Alex is out of the woods from a medical standpoint, our focus starts to shift. We begin thinking long-term. And one of the absolute biggest long-term issues in spinal cord injury is managing the urinary system. And this isn't a one-and-done kind of deal. We're talking about an annual surveillance plan. It's a 3-step process. Step 1, we screen to see how well the bladder is emptying. Step 2, we do a formal urodynamics assessment to get the nitty-gritty on bladder pressures and function. And finally, step 3, the most important one, we use all that data to protect the kidneys from long-term damage. All right, on to section 5, bone health. This is what you might call a silent complication, because you often don't know there's a problem until something bad happens, like a fracture. The rule here is super simple, and there's no wiggle room. 1 DXA scan every single year. This is not optional. It is the absolute standard of care for monitoring the bone loss that we know is going to happen after a spinal cord injury. What we're looking for is something called sublesional osteoporosis. Sublesional sounds fancy, but all it means is below the level of the injury. And it makes sense, right? The parts of the body that aren't moving anymore don't get that daily weight-bearing stress that keeps bones strong. So they start to lose density, which really ramps up the fracture risk. But just getting a picture isn't the whole story. We also need to run some key blood work, specifically vitamin D, calcium, and parathyroid hormone. This panel helps us find and treat any deficiencies, but it also alerts us to an acute risk of what's called immobilization hypercalcemia. Okay, we're in the home stretch now. Section 6, your clinical checklist. We've covered a ton of ground, so let's boil it all down into a practical checklist you can use for Alex's long-term care. So here it is, your high-yield checklist for annual surveillance. For the urological system, annual urodynamics. For the skeletal system, an annual DEXA scan. And for the metabolic system, that annual blood panel for vitamin D, calcium, and PTH. If you consistently do these three things, you're building a really solid foundation for long-term health. So here's the bottom line. You now have the clinical framework for what to monitor in a patient like Alex. But that brings us to the final piece of the puzzle. And honestly, it might be the hardest part. It's one thing to know what to do, but how do you talk about all of this with your patient? How do you communicate these complex results and these lifelong risks with compassion and clarity? That's the real art of medicine, isn't it?